So, hello, everybody. I'm Peter Merkel from the University of Pennsylvania. I know most of everybody, I think, here, many of the OMERACTors. I'm such a good OMERACtor. I even have kept my 2014 Budapest OMERACT tag, so you can see that my name really is Peter Merkel in the spirit of OMERACT. I want to thank everybody for joining us. We welcome systemic sclerosis, scleroderma back to OMERACT. It comes, it goes, it comes, it goes. It's been part of OMERACT for some time and attacking it in different ways. This actually started in 2004 in the Brisbane meeting, and then it's come and gone in different formats. This is a new group, which I'll introduce in a second, and it's been a terrific experience. I want to first thank people who should be thanked a lot, which are Bev Shea and Shauna Grossleg. Bev has been a terrific partner in leading us as we do our work and keeping us OMERACT honest, and Shauna for putting up with Bev and everybody. And so I want to thank everybody. Today's is a special interest group on vascular manifestations of scleroderma, which is a piece, if you looked at hopefully you saw the intro video by Ariane Herrick, that's a subset of this multi-system disease. I'll give you a little intro quickly and why we're doing what we're doing. We're going to hear from two different patients who have been full partners with us from day one of this working group about their experiences with these manifestations of disease. We're going to hear qualitative research, a summary of what's gone into this thinking, and it'll make you very clear why we're doing it from get-go with patient input. We're going to have a summary of our systemic literature review to date and the plans for that, which are fairly extensive, and then the next steps as we lead towards our goal of a core set of domains. And then we're going to actually leave a lot of time for questions and open discussion. So what is scleroderma? Just to remind you, it is it's also called, so systemic sclerosis and scleroderma are the same thing for our purposes here, scleroderma meaning hard skin. It's a fairly rare multi-system autoimmune disease that involves inflammation, vascular disease, and fibrosis. It is skin hardening, which is the scleroderma, thickening and color changes are the most identifiable aspects of the disease, but the disease involves many manifestations. It ranges from an annoying to a very life-threatening disease. And in most patients, it is a life-changing disease because there's a substantial impact on patients' health, function, well-being, sense of self. It's a difficult disease to have. This is why, because it has many manifestations of disease across a variety of organ systems. I'll start with the skin. Again, this is the most cardinal feature, but by no means the only feature. You get thickening and hardening. And what you can see here is what happens when patient's skin gets tight and thick. It changes colors. There's some vascular markings. Often it's so tight that they have trouble opening and closing their hands. And this happens in multiple areas of the body. On the left, on the right rather, you can see hardening of skin in this woman's chest, and her face is changed by this disease. Can be disfiguring, and that can do something to your self-image and how people view you. It's also difficulty from a function standpoint. Pulmonary disease can be life-threatening, pulmonary arterial hypertension or interstitial lung disease. There's another working group in OMERACT working on interstitial lung disease, and that group has already made good advances and is going to move forward with some instrument work and other aspects of ILD. There is myocarditis and pericarditis, heart disease leading to heart failure. That can happen. It's not that common, but it's bad. There's a lot of GI manifestations in terms of reflux, lots of heartburn. It's a big problem. Bleeding and dysmotility causing all sorts of problems. There's something called renal crisis. You never want to have anything that has the word crisis in it. It is a very serious problem, although it's actually treatable now much better than it was. There are arthritis and arthralgias and myositis, muscle disease. That's fairly common. And you can get secondary Sjogren's syndrome, neuropathy, and other things. And what we're talking about today are the vascular manifestations. Raynaud's phenomenon, which we will call RP, and digital ulcers that we will call DU or DUs. And there are other vascular manifestations that I previously mentioned. This is a disease where the manifestations are straight from the pathophysiology. So this is Raynaud's on top, the classic color changes. Often we talk about three color changes, blue, red, and white, not necessarily in that order, usually reverse order. And it can be, again, annoying, or it can be very life-threatening where you get gangrene, you can lose digits, and it can be very painful and disabling. And digital ulcers, which are a combination of vascular problems and vasospasm. So Raynaud's is the vessels closing down, but there can be permanent changes to the vessels, and you can get this necrosis and these ulcers, which are very painful and problematic, and you'll hear more about those. Everybody with digital ulcers also has Raynaud's, but not everybody with Raynaud's has digital ulcers. So what's the challenge of studying this? As I mentioned, this is, there are fixed aspects to the disease. This is an angiogram. There's the pore flow. This all should be nice lines of blood going to the fingers, and there's reversible aspects. So it's multiple things going on, makes it interesting to study and complicated, and it changes over time. It impacts how patients feel and function, and occasionally survive. It's quite different. The perspectives of patients and physicians are quite different. And as is often the case in disease, and both perspectives are important, and thus both perspectives are critical in evaluating what's going on. We really can't evaluate how Raynaud's is. Physicians basically talk to patients and then report it. Well, why not just talk straight to patients and ask them? So scleroderma-related Raynaud's and digitals have important differences from the same problems in other diseases. That is, Raynaud's occurs in lupus. Raynaud's occurs in myositis. But it's different, and it's different because there's more vascular disease. There's more of a problem in scleroderma generally, and digital ulcers occur much more frequently than in some other diseases. Furthermore, some people may have Raynaud's, some of you may have Raynaud's, I hope not, but people get it often young women at young ages and teenage years. That's primary Raynaud's. That's much less problematic generally. It's a different thing in scleroderma, so it deserves to be studied separately. The definitions are not standardized. This is actually a problem, particularly for digital ulcers. There have been studies done by some of my colleagues on this where you look and different physicians rate things as healed or not healed differently. So there's a definitional problem for how you even define these things. And we have moderately good therapy for some forms of Raynaud's, but for the more serious type in scleroderma, not so great. We have some that are effective, but not in everybody. And we definitely need much better therapies for both Raynaud's and digital ulcers. The goals of our working group were to develop a core set. Our overall goals is to develop a core set, but first a core set of domains that captures the full burden of illness for scleroderma-related vascular disease, including both Raynaud's and digital ulcers, receive buy-in from the international scleroderma research and patient communities, and endorsement by OMERACT for a domain core set, and subsequently proceed with the development of a core set of validated outcome tools, measurements and tools to study scleroderma-related Raynaud's phenomena and digital ulcers. This is our working group. There are 4 chairs from 3 different continents: Ariane Herrick, John Poling, Susanna Proudman, and me. And we've had 2 terrific fellows, Mike Hughes and Nancy Maltez, who you'll hear from today. We have 2 wonderful patient partners you're about to hear from, who've been with us, as I said, from the beginning. We have our OMERACT therapist, Bev Shea, who has been helping and leading us along the way. And we have Dr. Park from the NIH, is a wonderful liaison, and they've been very supportive of scleroderma research. So we're going to go through the literature review and domains to study this. We're going to summarize the qualitative research, and this is what our work plan has been, to do both of these things in collaboration. Those will lead to our work on the Delphi with patients and physicians to talk about domains. We will draft a certificate of domains and apply filter 2.1 to the draft domains and obtain endorsement of the core set from OMERACT, hopefully by OMERACT 2022, and then get into the fun of developing an actual endorsed core set of domains and matching instruments. That's our overall goal. So I'd like to stop there. If you could, again, you could put questions or comments in the chat and we'll follow, but I want to move on to, I think we're going to start with Virginia Hickey, a patient partner who will give us their experience of Raynaud's, and then move right into Edith Brown, and they'll introduce themselves. They've been wonderful partners from the very beginning, really helping us understand the patient experience. And I will add that they're not just patients themselves, but they're actually also in touch with other patients, patient groups, so they're able to bring a greater sense of the community to our work, and that's been terrific. So, Virginia.
Thanks, Peter, and hello, everyone. I'm Virginia Hickey from South Australia. I was diagnosed with diffuse scleroderma when I was 56, and at that time also learnt that I had Raynaud's phenomenon. But with hindsight, I had suffered the symptoms of Raynaud's as long as I could remember. I'd had cold hands and feet, and so had my father. So that part of my diagnosis didn't come as such a shock, and probably was the least of my concerns. And later, Peter went through some of the other problems with scleroderma, and I did have a renal crisis, which was pretty significant. But this story is about Raynaud's, and so my Raynaud's, I think, manifest in what seems to be a fairly typical way from what I've read. So it's the cold hands and feet, the changing of colours that Peter just described, and it's interesting. Cold weather, of course, brings it on for me. That's really the main trigger. Although interestingly, I can travel to the tropics and go, on a work conference or to a hotel and still get Raynaud's in the hotel because of the over air conditioning. So sometimes there's no escaping it. My treatment has been to largely in pharmaceutical terms has been nifedipine. And other than that, I spend a lot of time trying to manage keeping my hands and feet warm. I'm fortunate that I live in a fairly mild climate, but it gets cold. And so I spend a lot of time avoiding exposing my hands and feet in the cold climate because it's so hard to warm them up again. I spend a lot of time searching out different types of clothing to keep me warm, the hands, the gloves, the socks, the warm bars, heat bags, all those sorts of things that can help ameliorate the symptoms. I also try to keep my body temperature, my core body temperature warm. That seems to help as well, and wear hats and things when I go outside. One thing I did find really useful was a battery operated ski gloves that really helped me when I was in the snow, and I've actually used it even just at home sometimes to just keep things under control. So they're the symptoms that I have had. In terms of the impact on my life, perhaps because I had previously had symptoms, although they did get worse, it hasn't been too bad, but certainly it interferes with things that I want to do. I have a bike, I like to ride. If I go for a early morning ride, even with gloves on, my fingers will often just freeze up and I'm unable to control the gears on the bike. So that obviously makes it dangerous, and so I start to avoid doing that. Likewise, swimming, if the water isn't really warm, I like to swim for exercise, but that can be time limited because the toes turn to ice blocks. On a more day-to-day basis, just fumbling with things, putting coins in parking meters, or, anytime I have to take off my gloves in the cold weather, then I do have trouble manipulating things with my fingers. And interesting that seems to coalesce with the other problem of scleroderma, with the hardening skin on my fingers. So one way or the other, it can become a bit of a fumble. So that's really my story. I'm lucky that I haven't really suffered pain from Raynaud's, but I did have a digital ulcer a couple of years ago, and that was very painful. I'm fortunate that resolved fairly quickly, and touch wood, I haven't had another one since. But Edith, our second patient research partner, is going to tell you more about the digital ulcer side of things.
Hello everyone, my name's Edith Brown and I'm speaking from the north of England. I was diagnosed with systemic sclerosis about 20 years ago, and my first symptoms were Raynaud's and difficulty swallowing. Later on, I started developing digital ulcers on my fingers, my thumbs, and my toe. The most painful ulcers are usually on the ends of my fingers. Before I developed scleroderma, I could never have imagined the digital ulcers could cause so much pain and have such an impact on my life. The pain can be excruciating, especially if the ulcer becomes infected or if I accidentally knock my finger. It's the only aspect of scleroderma which has ever reduced me to tears. They can take an age to heal. They can last for many weeks and many months, and sometimes they do come back. Ulcers can impact on every part of your daily life, your home life, your social life, and of course on your working life. Many people develop scleroderma in their 20s, 30s and 40s, and those are the years when you're at your busiest, you're building your career and raising children and paying the mortgage, etc. And digital ulcers can make so many activities more difficult and a lot more painful. Ordinary things in life, like washing your hair, getting dressed, managing buttons and zips and shoelaces, cooking a meal or cleaning your house or using public transport, using coins in a machine in a car park or a station can really, really be painful. Practically impossible if you've got dressings on your fingers. Managing your medication for me is always been quite a challenge. I use an inhaler and I use a nebulizer. And can you imagine this little device here trying to get a little tiny capsule in your inhaler when you've got dressings on your fingers? It's no joke. And every scleroderma patient will tell you about these wonderful things, trying to pop pills out of a tin foil container. Digital ulcers, I think, cannot be compatible with many careers. For example, if you have a career in nursing or dentistry or catering or hairdressing, or using a keyboard or using machinery, or any career which demands a level of dexterity, could be quite a challenge. And every time you have to ask for help, it chips away at your self-esteem, at your independence, and makes you feel very vulnerable. And it certainly does dent your confidence. If alloprost infusion is recommended, you know it's going to be an excellent treatment, but it does require a stay in hospital. The treatment is great, but can you imagine having to ask your manager for another 5 days off work just to have an infusion? I certainly might worry that it would impact on my career. Will I eventually have to change my job or maybe give up work altogether? It's quite a daunting prospect for many people. So digital ulcers can be painful. They can also be quite scary. If they don't heal, you start worrying what's going to happen next. Will I need surgery? Will I need debridement? Will I even perhaps need an amputation? And if the digital ulcers start getting worse or more frequent, or they keep coming back, you might also worry that that is an external sign that your scleroderma is getting worse internally as well. So digital ulcers, there you have it. Not for the faint-hearted. Thank you.
Well, now you know why we are so happy to have these patients with us. Really, I think, fantastic partners. You can hear much of what we are trying to the challenge of studying this disease and why we really need to get better treatments. So thank you for that. Mike Hughes is going to talk about qualitative research he and John Poling and others have done. That has really been great to start us off, and it gave us a tremendous head start on the work we're trying to do for domain selection. We see you, but we do not hear you.
Is that better?
Yeah, yes, now we hear you for the first time.
So I'm presenting a summary of our qualitative research to date on SSE, RP and DUs. So initially we undertook 2 systematic literature reviews of sclerosis RP and DUs, as we can see here. And it's quite striking, between the 2 manifestations, we can see common themes. So first off, systemic sclerosis, Raynaud's and digital ulcers, they cause distressing physical symptoms, impaired function, body image dissatisfaction, and reduced quality of life. And also there's major limitations to how we approach assessing not only Raynaud's but digital ulcers. And this has a major impact how we test new treatments in clinical trials for much needed treatments. We've undertaken qualitative research with focus groups in 2 continents for Raynaud's and in the UK for digital ulcers. And we can see here conceptual frameworks on the left for Raynaud's, on the right for digital ulcers. And these are the themes and sub-themes that represent the patient experience of digital ulcers. And for the interest of time, I'll focus on digital ulcers on the right, but there's major overlap and interaction between the two. So as we might expect, digital ulcers are characterized by major physical symptoms and signs, particularly pain. There's broad range in psychological impacts, including fear and the need for constant vigilance. There's functional impacts, which are broad ranging as well, including all activities of daily living, but also interaction with work activities, a number of aggravating factors, including temperature and trauma, but also a number of mitigating factors, including self-management and the use of devices and aids. So our qualitative research to date is leading to the development of really novel patient-reported outcome measures, the ASRAP, which is for Raynaud's phenomenon, but the CDU questionnaire as well for digital ulcers. We've recently undertaken an international patient survey, the PASRAP survey, which included almost 750 patients with systemic sclerosis, and this captured the patient experience in 46 countries and 4 to 5 continents. And this confirmed qualitative research that we've done to date, but also more broader aspects of digital vasculopathy, including digital ulcers. We've also undertaken extensive research in qualitative understanding of Raynaud's and digital ulcers. So Dr. Pauling identified that patients can identify different patterns of Raynaud's, and this changes over time. Patients can predict digital ulcers and they have explanations, and ulcer symptoms change over time. And patients have very rich narrative devices which they use to describe digital ulcer pain. Thank you.
That was great. And I think we'll go right to Nancy. I want to just go ahead and show who's going to talk to us about the systematic literature review. You're good.
Oops. Sorry about that. So hello, everyone. I'm Nancy Maltez, rheumatologist from Ottawa, Canada, and fellow on this team at Vascular Disease and Scleroderma Working Group. I'm going to take a few minutes to present an update on the progress made by myself and Dr. Hughes on 2 parallel scoping reviews aimed at informing this team's initiatives. This, of course, under the leadership and guidance of the rest of the working group. 2 parallel scoping literature reviews are well underway. The objective is to evaluate the domains of illness studied, the range of outcome measures used in clinical studies pertaining to patients with Raynaud's phenomenon and digital ulcerations, particularly in patients with systemic sclerosis. Detailed study protocols were prepared. Broad search strategies were developed with the help of an academic librarian, and final database searches were performed earlier this year. Here we see the PRISMA flow diagram for the review pertaining to Raynaud's phenomenon. In summary, 4,899 abstracts and 147 full texts were screened with predetermined selection criteria. 64 studies are to be included in the final analysis. Similarly, for digital ulcerations, 3,743 abstracts and 123 full texts were screened with a final 39 included studies. Detailed extraction forms were developed, piloted, and approved by all participating work group members. Data extraction is nearly complete. Thus far, preliminary review indicates that attacks, cold response, perfusion, function, and pain are common domains assessed in studies pertaining to Raynaud's, whereas ulcer count, improvement, function, and complications are most commonly seen in those assessing digital ulcerations. The next steps in advancing both scoping reviews include completing data extraction, meaning identifying remaining outcome measures used, and summarizing variability in measurement tools and time ascertainment. These results will inform the eventual development of a core domain set for both Raynaud's and digital ulcerations in systemic sclerosis. Thank you.
That was terrific. So that groundwork will lead us to where we're going next. I think we'll jump right to John Pauling. Can you share your screen? Who will bring it together? How we're going to take the data from these two streams and move us forward to domain selection and beyond.
Thank you, Peter. So I'll talk about the next steps.
Tell us who you are. Tell us who you are.
Pardon, sorry?
Tell us who you are.
Oh, yes. So I'm John Pauling. I'm a rheumatologist working in Bath in the UK, and have an academic interest in systemic sclerosis and particularly digital vasculopathy. So we've been hearing from the rest of the team about the work we've been doing so far. I'm just briefly going to walk you through the next steps of the group. So having undertaken this preliminary work, we will hopefully have generated a list of candidate domains for both Raynaud's phenomenon and digital ulcers. And then with the support of Bev O'Shea and Shauna, we'll be then using Delphi Manager to undertake a consensus building process to help prioritize these candidate items. And the Delphi exercise we hope to undertake with patients through patient organizations such as international groups like FESCA and national groups such as Scleroderma Raynaud's UK and other national patient organizations. And then we also hope to run the Delphi with clinicians, and that includes doctors and allied health professionals, both with an interest in systemic sclerosis, but also with an interest in outcome measured development. And we hope that many of you on the call today will be able to support this work. So we'll use this to formulate a draft of core domains and core contextual factors. And then the working group then will review this work and the consensus building approaches, and then submit a draft core domain set to the technical advisory group within OMERACT. And we hope to take this work to the next OMERACT meeting so that we can vote on this as part of a working group. And the hope is that we'll be able to then get endorsement from OMERACT 2022 workshop in terms of the core domain set, using the paradigm that's been applied to multiple other disease areas within OMERACT. So we'll be presenting all the quantitative and qualitative research and the consensus feedback received during the whole process, and then undertaking formal voting on a provisional core domain set. Thank you.
Great. So that's what we've been doing for the last some time now, actually, but I think this group's moved incredibly quickly and quite nicely. I'm going to turn it over to Susanna Proudman, who will introduce herself and is going to lead us in a discussion, and all of us can be involved in answering questions as need be. Do you want me to throw up? We have actually an early poll question. What would you like to do first, Susanna? And we'd love you to, people can put comments in the chat, et cetera, et cetera.
Peter, it would be good to be ready to show the discussion questions, if you wouldn't mind. Thank you. I'm Susanna Proudman. I'm a rheumatologist in Adelaide and have been interested in scleroderma research for quite some time. So we've heard about the wonderful qualitative work from John and Mike, and Nancy and Mike about the systematic literature review. We are now getting some indication of the candidate domains that could be included in the core domain set. So once these set activities have been finalised, we'll be ready to go to the Delphi for developing core domain sets for Raynaud's phenomenon and digital ulceration. And we'd like to use the next little while to turn it over to you, all you wonderful people who've joined us on our SIG this evening, wherever you are in the world, to hear your view on the work we've done to date and try and help us identify any gaps or other areas of research and endeavour that we should perhaps undertake before we will be able to achieve our ultimate goal for this phase of the program, which is to develop the core domain sets. So we have some questions that Peter will.
Yeah. So why don't we tee up our poll question? We have a first poll question, which will probably get us rolling. Can we read that, Susan?
Yeah, so perhaps we could have some discussion about this before we actually put this to the poll. So many of you have been involved in our OMERACT activities in the past or currently doing so at the moment. And the various stakeholders can range from patient research partners and other patients through researchers in the area and really anybody with an interest in the disease, but also those who perhaps are involved in other OMERACT activities and are not so familiar with the disease under study at the time. And we have wondered how this would impact on our selection of stakeholders for the Delphi. Scleroderma is a complex disease, as we've heard today, and it is a somewhat niche activity, I guess. There's a community of rheumatologists in particular who are very interested in this disease, researchers interested in this disease, but it's often the disease that rheumatologists refer on to other rheumatologists for, not rheumatoid arthritis, where everybody has an exceptionally good working knowledge of the disease and it feels comfortable managing the disease, even at the forefront of new therapies, research and so on. So we have started a debate about whether we should take all comers for the Delphi, or should we be limiting it to the patients who experience the disease, which is fairly usual, although occasionally other patients for broader questions about contextual factors and shared decision-making in other groups involved in OMERACT might be involved. Should we limit it to just those patients who experience scleroderma? And likewise, should we take all comers who are interested in the OMERACT process and decision-making about core domains and so on be involved in the Delphi, or limit it to those people who are really quite experienced in managing or researching in scleroderma? So we'd be interested in really any comments from the group, anybody on the line, about whether we should be keeping this very broad or limiting it to those who have personal experience. Feel free to make comments in the chat or simply shout out, because we'd like to get the ball rolling.
This is Vicky Evans from Australia. I'm a patient research partner. I have a question about this. By providers, are you also including the regulatory folk or people who are representing some drug approval organisations?
We haven't made a definite decision about really anybody who should be doing the Delphi. So that's a very good point, Vicky. Certainly there are many pharmaceutical companies that have developed a relatively recent interest in this disease, and we've been fortunate in fact to have clinical trials. So they're particularly interested in these sorts of outcome measures because that's probably limited our capacity to prove that therapies work, or maybe we don't have any therapies that work yet, and that would matter what outcome measure we had. But until we have good outcome measures, we won't know whether they are in the process of developing effective therapy. So they're very interested in this. So what do others think, including the stakeholders?
I'm going to explain something, which is that we actually have a parallel process that's occurring with many of the same people, looking at Dinesh Khanna and I, who are he's on the line as well, leading a group internationally to look at outcome measures, really the instruments actually that would lead to approvability by the FDA and other regulatory agencies. So that is happening sort of in parallel. John Poling is actually leading that task force, as is Ariane Herrick for DU and RP. So that is being informed. So we need to think about how to bridge those things. I think the industry tends to be interested in the instruments that will actually lead to that they can measure in a trial, but obviously you can't have a good instrument if you don't are measuring the right domain. So I think it's a good point. We are often, unfortunately, forced to explaining the disease to them once they come into the space.
So maybe we could hear from scleroderma doctors about whether you think that other rheumatologists and other clinicians in this area should, or broadly without a specific interest in scleroderma, should participate in the Delphi.
Hi, this is Francesco Ricardo from Leeds. Just to get the ball rolling, I would agree with Peter that while the inclusion of methodologists can always help because they always give you, they always give different points of view, the having to explain also sometimes pretty basic things of scleroderma to people not in the field, it shows right away what's the limitation of the process and the results. So in this view, I voted to keep it to people, to patients, of course, that experienced the burden, and to doctors that have experience in managing the disease. I would add some methodologists outside the field, but as far as rheumatologists, I think it's important to have experience in this disease.
Yes, Susanna, Dinesh here. I can maybe add a little bit to this. I think I mean, there's absolutely no doubt in my mind that the patients should be central to it, especially when you think about Raynaud's phenomenon. Raynaud's is a subjective, it's a symptom, and I think the clinician to me has zero, if any, role in determining how to measure Raynaud's phenomenon, whether it comes to frequency, severity, and the aggressiveness of it. I suppose for digital ulcers, I agree with what Peter and Francesco said, but we have done a dismal job in scleroderma, including myself, developing outcome measures that are able to capture the field function and also other aspects. So getting other experienced clinicians from outside scleroderma, some chosen one, may not be a bad idea to get their perspective as we take the next steps out here.
Thank you. Can I quiz Delgado a bit more about how you define a methodologist? Is that all OMERACTors?
Yeah, that is an interesting question, is it? Not sure. I would echo what Dinesh said. People with experience in developing outcome measures is what I would define a methodologist in this field. And of course, people that have dedicated their academic and clinical interest to scleroderma, sometimes for decades, might not have experience in developing outcome measures. So that is the experience that we could borrow, we could build on. And so in this sense, yes, I would agree. And that's what I was defining methodology. So people, some rheumatologists that have a proven experience in developing outcome measures that have eventually helped in another disease area.
So I would differentiate, I think this is a great discussion, Suzanne. I would differentiate this step, which is what to measure, the domains, from how to measure, which are the instruments. And I think that's the big difference. So I would posit that what to measure does require some significant knowledge of the disease spectrum. How to measure it probably involves a larger group, as people have said, about feasibility and using measures and bringing new science in. I mean, Ariane Herrick works with a physicist to think about how to measure some of these things. So I just think we tend to—
I would agree totally, Peter, yeah.
I don't know what other people think.
May I ask another question? This is a bit of a side one. So I do not have scleroderma. I have AS, I also have Raynaud's. I also get ulcers on my toes every winter, which I've been told are chilblains. So there may be groups of patients that who don't have scleroderma, but can understand some of the debilitating consequences of these lesions on your fingers and toes. And so there's a question in my mind about the value of including a broader group of patients or restricting it to just those who officially have scleroderma as well. And I'd like your thoughts on that.
So we've made a distinction between the Raynaud's phenomenon experienced by people with scleroderma and Raynaud's occurring in other conditions, partly for convenience to try and streamline the process, because we know that Raynaud's may not be the same in other diseases. Idiopathic Raynaud's most certainly is not the same. But I agree that the personal experience may well be the same. Whether we can identify those people outside of the scleroderma patient groups may be logistically a challenge. But what do other people think about Vicky's comments about the generic view as opposed to the disease-specific view in selection of patients?
Pathophysiologically, they really are different. They're really different. There's a different thing that's happening at the vessels in scleroderma that doesn't happen in other diseases.
Yeah, I'd echo Peter's comment there, particularly when it comes to cutaneous ulceration, so skin ulceration. The skin ulceration of lupus is very different to the skin ulceration in antiphospholipid syndrome, which is very different to the skin ulceration we're talking about here in scleroderma-related disorders. I think Raynaud's, is an area where I think there is slightly more shared pathogenesis between the different disease areas. And some of the patient organizations we'll be targeting, such as Scleroderma Raynaud's UK, do have a number of patient representatives who actually do come from that broader spectrum. So that'd be information we could potentially collect as part of the information of respondents who take part in the Delphi, and we could explore that. So I think it's a great suggestion.
Well, are there any other comments on this topic before we start the polling? In that case, we have the question on the screen already. Thank you, Bev. The question is, do you agree that limiting the Delphi to patients and providers experienced with scleroderma is the right approach for this complex and rare disease? Please vote yes, no, or not sure. So just while we're doing that, we've had a comment comments from a couple of other patients, I believe. One was an agreement with Vicky as a dermatomyositis patient. Certainly that's a disease that can have quite debilitating Raynaud's and ulceration. And another comment, maybe those other groups of patients could be recruited as a contrast group to measure the usefulness of the outcome measure. Yes, so that's not to say that there may not be further work once tools and instruments are developed to see how they perform in other groups. That's correct. Now we have results. So 74% agree, 12% not say no, and 14% not sure. Really interesting result, actually, because it seemed in the way the discussion was going that it would be all four. Clearly it's a positive result. But we do have some people who are not so sure on including others. So I think having had that discussion, we've teased out the issue of generic polling in a Delphi versus targeting it to people with expertise or experience. So we can take that on board when we come to developing the Delphi and the subsequent activities. So turning to our next question, which is really more one for discussion. So please use the chat or call out if you have things to say. We can always quiet you all down if it just gets too rowdy and take it one at a time, but we're really just keen to get everybody to be involved in the discussion. So one of the issues that's come up is this issue about where there is similarity between Raynaud's phenomenon and digital ulcers, and where there are differences both in the experience and the outcomes and the tools that might be required to measure these various domains. So remembering the domains that have actually been measured in trials to date that Nancy showed us on the screen, there were some similarities. Pain and function were common to both. Then there are other ways of actually trying to quantify the burden of the disease in terms of the numbers of attacks for Raynaud's or the count for digital ulcers, and then other contextual factors which might trigger or these phenomena versus represent a change over time. So Raynaud's tends to be something that you have, comes and goes in terms of individual attacks on a daily basis, but once you have it, you more or less have it. Whereas the digital ulcers, they come and go, and there may be intercritical periods where there are no symptoms at all. And then there are quite significant complications that can evolve with digital ulcers versus Raynaud's. And I guess the key issue is that everybody with digital ulcers has Raynaud's, but not everyone with Raynaud's will get digital ulcers, despite the fact there is this overlap in pathophysiology and epidemiology. So we've seen in the systematic literature review that there are trials that can address simply Raynaud's alone, digital ulcers alone, or both. So one of the things we'd like to talk about is what impact these various concepts might have on the domains selection process for Raynaud's and digital ulcers in scleroderma. Should we be trying to lump them in together, separate them completely, or do something in between, some sort of hybrid where we can measure some similar features? Or is the pain different in the two diseases and need completely different tools? The impact on function completely different, need completely different tools, and should we be keeping them separately? Might be interesting to hear from, starting with some of the patients, how they feel about these two phenomena, whether they are really quite separate, or whether you think you could put the two together, or whether you sometimes can't tell the difference, whether it's your Raynaud's or digital ulcers that's causing the problem. Maybe either Edith or Virginia might like to kick us off.
I think the pain and the disability are very different, actually, in both conditions.
So if you were being asked about these two phenomena in a clinical trial, for example, do you think you could distinguish between the impacts from both, and in other words, have two completely different tools to measure them, or would you find it difficult to tease them apart?
I think they're very different. In the chat.
That was my experience too, that the ulcer, I wouldn't have confused the two things. I don't think they felt different.
Do we have any other patients who'd like to tell us their experience?
Edith, I'm not a patient, of course, and I'm always impressed when Edith talks. And I was impressed about how many times she mentioned the word dressing, which is something that we don't consider, right? We take it as a fix and a way to help, and it does. But the effects that the dressing have on their daily life is something that I probably have underestimated so far in my clinical management. So can you tell us a bit more, Edith, about dressings, how these dressings actually bother you and causing you disability compared to the pain?
I think having a dressing on your, can you hear me okay?
Yes, thanks, Edith.
I think having dressing on your ulcers is obviously very important in certain circumstances, particularly if they're starting to weep or they're obviously infected. And obviously your scleroderma clinic will advise you whether to keep it dry or whether to keep it moist, etc. But the dressing itself can be quite disabling, because there's certain things you can't do, and you're very conscious to keep the dressing clean and dry. And I always get through an awful lot of latex gloves in trying to perform ordinary everyday activities without injuring my dressing as well as my ulcer. But I think trying to do without a dressing is quite, it's quite another problem.
I see a confusion here in the word dressing. We have to be very specific about the use of the word dressing here, don't we?
Right. Are you talking about having like a bandage on something on your finger?
Yeah. Yes.
Is that what you're talking about? Yes.
Yeah.
Yes.
Once again, English has just not been spoken around the world anymore. We speak American and Australian and various other variants.
That's English.
Yes, for the non-British, including myself, it's a plaster, yeah, and the bandage that are used on digital ulcers. There's nothing to do with salads. No.
Actually, all kidding aside, it actually brings up a good issue, even when we have Adelphi, even when we bring these issues up, is to make sure
you're absolutely right.
It's translatable. As we know, we have spoken English in this continent for for 100 years. So.
Do you have any other thoughts from clinicians or other methodologists in the group?
I'll just throw this out there for the team, which is that, right or wrong, trials have actually often studied these together. Studies of Raynaud's will record whether they're in scleroderma, will record whether digital ulcers occur. And studies of digital ulcers will certainly record the activity of the Raynaud's, because, as we've said, everybody with digital ulcers has Raynaud's, and many people with Raynaud's and scleroderma have digital ulcers. So it's somewhat convenient, but we're hearing a lot about how they're separate. So there's a practicality to collection, but that doesn't mean the domains have to be the same.
Hi, this is Ashima. Can you hear me?
Yes.
Mm-hmm.
Yes. So I just wanted to chime in as well. And just from seeing a lot of patients with scleroderma, I feel that, these two components from a domain perspective, while the feasibility so far has been such that we want to collect everything together from a convenience standpoint, it does seem that the two need to be separated out maybe for future trials and assessment of each of these separately, just given that patients tend to associate a lot of episodicness with episodicity with their Raynaud's, and in between their episodes they may not actually be as uncomfortable as in comparison to a person with digital ulcer who has pervasive sense of discomfort and pain in conjunction with that manifestation for days on end until it's completely healed. We're counting more episodes with Raynaud's in terms of the daily frequency and severity, but then with ulcers we often depend on counts, and that count may be the same for the next couple of days or weeks, but maybe different if we add a different time frame to that measure. So I do feel that the two may need to be assessed a little separately from a patient reporting outcome perspective.
Yeah, that's a very good point. What about life impact? Yep, Francine has put in the chat. Symptoms and signs may well be different, but what about the impact on life? Do any of the patients have any view on that? Is it the same whether you're having Raynaud's on and off or digital ulcers all the time? Would you be measuring the same domains, use the same instruments, or keep those separate for that impact as well? Peter's chosen to write instead of talk.
I'm a quiet, unassuming man who doesn't like to.
More reason to define the domains and measure them together in cohorts and trials.
Find them separately, but measure together so that we can separate out. That's, I think, the concept that our group was thinking about, which is figure them out separately, but then there's a lot of overlap in the group, so measure them, and then you can separate out. I think it's an interesting problem. I would also add there's a great spectrum. Mild, Raynaud's, severe. No such thing as a mild digital ulcer, but there are digital ulcers that are bad and there are digital ulcers that are real bad. And there's 1 digital ulcers and there's 5 digital ulcers. But none of them are good.
So one of the other domains that we could measure, certainly came up in the systematic literature review, is more pathophysiology, maybe that sort of trying to measure the circulation and the microvasculature could be another domain. Could I ask maybe Ariane to tell us whether she thinks the same tools that measure perfusion could apply to both digital ulcers and Raynaud's, or whether you would only use it for Raynaud's, for example?
Okay, no, thanks very much, Susanna. I think it's a very interesting discussion, and I think to separate them, Raynaud's phenomenon and digital ulceration completely is quite a challenging task, because at the end of the day, they're part of the same spectrum, although the constructs are a little bit different. But your specific question about measurement tools and instruments, I think they will be different for measuring ulceration versus measuring the Raynaud's attacks. But having said that, the severity of the digital vasculopathy, which I think can be assessed using non-invasive measurement tools, for example, laser Doppler techniques and thermography, will be relevant to digital ulceration, because it's the severity of that digital vasculopathy that underpins the ulceration. So that's perhaps a rather circuitous argument, but I think that, as Peter said earlier, I think you may well want to document the severity of the vasospastic element aspects to inform the actual ulcers per se.
So it's interesting that in the SLR, perfusion hasn't come up in digital ulcers yet. So that will be a domain that hasn't been tested perhaps in trials before for digital ulcers, although it has been looked at in Raynaud's phenomenon. So,
it's definitely, Susanna, it's definitely there. It's just not, we had the top 5, so it's definitely there.
6.5. I think, so Ingrid has a very good point in the chat. Ingrid de Groot, pain seems a preliminary outcome in both DU and RP. Outcome measures might differ in the sense that pain questions Thoughts on that from folks?
Yeah, I think from the qualitative research we've done, I've been struck by some of the differences in the quality and the wording patients use to describe their lived experience of Raynaud's versus digital ulcers. But when people are describing their digital ulcers, they'd use terms like, it's like a volcano in the finger, and they really describe this intense, small area of really exquisite pain, whereas in Raynaud's, it's more diffuse. I think another important thing which really differentiates the two areas is the degree of control patients have. So with Raynaud's phenomenon, patients will report positive steps they take to ameliorate attacks and shorten attacks and prevent attacks from occurring in the first place. And I think that's a level of control that's not present in people when they actually have ischemic injury that leads to digital ulcers. I think we are beginning to unpick some of the qualitative differences that exist between the quality of pain and the impact on function and quality of life between these two disease areas.
I thank you, John. I would agree completely, and maybe just a provocation, but I didn't hear perfusion when Edith was talking, and neither I hear it any time a patient complains to me about the limitation in the hand function or the pain. So while I do think that perfusion can be a surrogate outcome for us to try and prevent digital ulcers, I'm not sure that perfusion is something that it might reflect the limitation that digital ulcers cause to patients when they have them. So it could be something that may be important in Raynaud's leading to digital ulcers, but when there are digital ulcers, we already know the lack of perfusion that is causing them.
would you like to know a bit more about the pathophysiology in both conditions, though, in terms of, you know, they may be reversible or irreversible, in addition to the patient experience? I guess that comes back to the sort of fundamental process of developing core domain sets in OMERACT, that sometimes they'll be focused on the patient experience and sometimes they'll be perhaps more objective measures. I guess my question was whether the perfusion side behaves the same in the two conditions. So,
I would make one more point. Andrea Murray makes a nice point. I think the objective measures serve different purposes to the PROs, except as I think Dinesh said, and I would agree, that there's not a lot of objective, as we use the term objective, which can be objectionable, to Raynaud's. When I evaluate Raynaud's, I ask the patient how their Raynaud's is doing. We ask them how often they're having it, how it's going on. So it's really all patient reported, unless they have digital ischemia and gangrene, which is a severe form. So we can pretend it's objective because the clinicians measure it, but it's not. It's completely based on the patient. So I'd be careful. Do we want to go to the poll? Do you want to go to the next question?
Yeah, let's go to the next question.
So the next question, you can read that because this, go ahead.
I'll read that. Do you agree with our plans to study Raynaud's phenomenon and digital ulcers both together and separately, given all patients with digital ulcers have Raynaud's, but the patients with digital ulcers are a subset of patients with Raynaud's phenomenon?
And I would add that our purpose of this is, again, we would agree with the conversations that have happened, which is the domains will almost certainly be different, or probably overlapping, but different. So we would measure them separately, but that from a convenience and from a patient cohort standpoint, studying everything together makes sense because there's a lot of overlap. And then we
So in other words, we'll develop a single Delphi that may have two parts. So everybody be invited to do the first section on Raynaud's, and maybe only those people who have digital ulcers would then do the section.
We'll analyze them separately.
Do everybody all together.
Or we'll analyze them separately based on whether you've had that experience.
May we have the poll, please?
Well, okay, there you go. Go ahead.
All right. Yes, no, not sure. Please vote now.
Just like to remind you that we do believe in elections in this country.
How are you going to count these votes?
Well, first it goes to the electrical body, goes to the states. It's complicated. It should take about a month.
All right.
Change will happen. Okay.
All right. So people seem generally happy with our approach, which is to try and take all these comments into account, to study these things together, yet separately.
You know, it's nice to get feedback because I think we've been talking to each other every month for months and months, and it's, you know, it's exactly that. It's our own echo chamber, so it's always good to air it out. This was our next question, Susanna?
Which is really a more general question. It's perhaps the question we might have asked at the beginning, really, which is more to invite questions of our speakers to see whether there are any other things that people would like to know about their presentations, and really more specifically, what is missing? What else do people think that we could be doing to develop this process of domain identification? So maybe if there's anyone who has any questions of either our patient partners, Edith and Virginia, or from Mike about the qualitative work, Nancy about the SLRs, or John about where we're going next, and general comments about what else you think we should be doing. Does anyone have any questions of Mike and the qualitative work? Perhaps to start with, he didn't have much time to cover a really enormous body of work that he and John have been doing.
Maybe we could ask Mike and John to speak to our sense from hearing it. We've heard it quite a bit. Is how you hear the same, not exactly the same, but you keep hearing the same themes as you go around, even though you ask things in different ways. When you want to talk to that there's a striking profile.
Yeah, John, do you want to speak to that?
You're speaking, but we're not hearing, so you have to unmute.
We opened each of our focus groups with an open question, which was to ask all the participants just to describe what Raynaud's phenomenon meant, or digital ulcers. We held this focus group separately. Obviously, we only included patients in the digital ulcer focus groups who'd had an experience of digital ulcers. So, but we started with a very open question: what does Raynaud's phenomenon, or what does digital ulcers mean to you? And just allowed patients to speak. And there certainly was a lot of overlap, and I think specifically around pain, which is clearly central to both of these experiences, although the quality of the pain, as I mentioned, does differ. And then function actually there was again remarkable similarities between the two, because digital ulcer pain is often made worse by cold exposure, as is Raynaud's symptoms. So, and the types of activities of daily living that patients reported experiencing problems in was again very similar. And I think another area of similarity was the emotional impact, and not just the frustration and anguish caused by these manifestations, but also embarrassment, when, you know, lots of patients described people often who they didn't know in shops, etc., saying, "What's wrong with your fingers?" And, you know, saying, you know, making their own judgments, which people found very distressing. So there was an awful lot came out of the focus group works that we weren't expecting to find, and certainly a lot of overlap between the two areas. As I've already mentioned, I think the main difference between the two is the degree of control that people have with Raynaud's that is perhaps lacking in people who are currently experiencing a digital ulcer. And probably on a similar point is then there is the issue of people who've had digital ulcers, about the constant fear they have about developing a new ulcer, either at the site of previous ulceration or on another finger, which is an issue that isn't so present in people with Raynaud's symptoms. Mike, I don't know whether you have any additional comments on that.
No, I think that's it, John.
So do the patients on in the survey, do they have any other, because that was really more a survey that where you devised the questions specifically, but did they mirror the same findings? Do you think there was anything new that came out of the survey?
Yeah, the survey, we knew less about the respondents because they self-selected themselves through patient organisation groups, but there was a much larger sample size and from a much broader range of countries and continents. And the actual qualitative thematic analysis from the analysis we've run so far is concentrated on an open question where again patients are asked to describe what Raynaud's meant to them. But the thematic analysis of that work was undertaken by a separate qualitative research team led by Dinesh Khanna over in Michigan. And we were delighted to see actually the same themes and sub-themes arise from that work. So, and no new domains arose, even though the sample size was many times larger. It was the same themes and sub-themes that seemed to come through.
So do you think there were different domains compared with what's come out of the SLR? Do you think we're missing anything from what's coming up in the top 5, for example? We haven't seen all the others, but the ones that were listed in the summary of the SLR, do you think there are any other major domains that we're not talking about at the moment? We need to add to that list.
Mike and Nancy, has emotional impact come through clearly in the work that you've been doing so far?
No, it hasn't. They're not studied in very many of the studies that have come up thus far.
That's probably
same for DU.
By physicians and not designed by patients, and that's I think a lesson to learn. I mean, we need to study. One point I forgot to mention early on is 95% plus of patients with scleroderma have Raynaud's. So this is an inherent part of this disease, just to remind, to the point where if someone doesn't have Raynaud's, we question the diagnosis.
Yes, very true.
Yeah, I think that is an issue with the SLR, as Peter says. We've had a tendency to study either what clinicians perceive to be most important, and a lot of the work that's in the literature is derived from clinical trials and registry work, which again is focusing on more traditional aspects that perhaps have been more highly rated by clinicians than patients. So I think hopefully,
or just easier, which is a cop-out. I mean, if you count ulcers, it's not easy to try to figure out the severity. I didn't say it was right. I think it's wrong, but.
So maybe we could I'll just run through what the SLRs identified for Raynaud's and then for digital ulcers, and see whether that prompts any other comments, either from from John and Mike, or from the patients who are on the line, or others. So for Raynaud's, we had the number of attacks, the response to cold, measurement of perfusion, and the effects on function, and measurement of pain. We've heard about emotional impact. Any other domains that we think should be included in Raynaud's that have come from the qualitative work or from personal experience? You can pop it in the chat or shout out.
Could you put up those domains again? The ones for Raynaud.
I think this is our last slide anyway, so Peter, could we go back?
I actually have all the slides, so let me do that. Which one would you like from Nancy's present? This one?
Nancy, yeah, the one just after that's it.
Yes, perfect.
So the answer is yes, I can do that.
Great.
I have very few
and
likes.
No time at all. Ask and ye shall receive. So what anything else we'd like to add for the Raynaud's, or if we're done with Raynaud's, any other domains that come to mind for digital ulcers?
And remember, this is just the top 5, right, Nancy? There are others, they're lurking below.
Yes, these were the most common.
I would remind people that, remind ourselves that something may be important, but only important to a subset. And so we have to be careful not to miss that. I guess I'd ask the group, the OMERACT group, where does one draw the line?
What is perfusion?
Should we ask Ariane to reply to that?
Perfusion is blood flow. And it's an interesting point, because most of what we've been saying about perfusion is about measuring blood flow in the fingers, because that's impaired in Raynaud's phenomenon. But in fact, you can measure perfusion within an ulcer. And okay, well, we'll be discussing that a long way down the line when we're looking at the different instruments. But you can actually, the blood flow within an ulcer itself is actually reduced compared to the adjacent skin. So in systemic sclerosis, a huge problem is that the blood supply is reduced and causes poor oxygenation, and that's what a lot of the problems derive from.
Yeah. No, I understand that. I guess the word perfusion, though, is confusing to me, in that you've just described 2 different aspects of perfusion. So how do you call that a domain or a candidate domain?
Yes, I don't think perfusion would be, well, I mean, that's open for discussion, obviously. I don't think it sits comfortably just in a single domain.
So if we're asking if we're missing anything, I guess my comment would be on that one, that maybe that needs to be separated into the 2 aspects that you just described.
I'm sure you're right.
It has its place, if you look at filter 2 and how we think it has its place under physiologic and biologic functions. So there are places to put these concepts, but they may not be domains. It's a good point, Tasha.
So we've had a couple of comments in the chat. The additional factors such as skin fibrosis or calcinosis, which obviously coexist with both of these phenomena, but perhaps could be considered contextual factors. I think there's been mention of that. And numbness, which is another symptom that occurs in Raynaud's, which may have come out in the SLR. We'll have to wait for the final report on those, but that's certainly a symptom experienced in this condition. We've got the digital ulcer position on any fingers, yes, so there are certainly differences pathophysiologically and in the impact of ulcers on the ends of the digits versus the extensor surfaces of contractures, for example. So that's a really important distinction to make in the study of digital ulcers. Pain and numbness again, and of course the long-term damage caused by Raynaud's. That's an interesting question about the acroosteolysis and the gradual loss of the tissue and even the bone in this process. So it's another really good thought.
That actually raises a methodologic conundrum, which is that people's experience with Raynaud's is maybe different in the first few years of their disease versus 10 years on, where they have fixed vascular problems. And so it's a challenge, but we can't probably have domains for first 5 years and second 5. I mean, we have to just sort of try to make sure we have a spectrum of people that we're studying.
So I think the next challenge, this has been a really wonderful body of work over a relatively short period of time, with particularly John and Mike coming quite prepared in the early stages with the qualitative work. But probably where it's going to start to get difficult now is with the instruments and what it is that we're actually trying to measure within these domains. It's been great progress on developing the domain core set, which we hope to present in a couple of years at the next OMERACT. But the challenge will be, what are these instruments actually measuring? And the fact there is such a spectrum of experience. Some people have very mild disease, and measuring change at that level of the spectrum will be something completely different from measuring change at the other end of the spectrum of much more severe disease and at different stages of disease. And side effects of the medication also been included. So I think we've probably come to the end of our questions and the things that we would like to talk about. We have, are there any other comments or questions before we wind up? Triggers have come up too. Yes, other things apart from cold, such as stress, include cigarette smoking and so on in that as well. All right, well, thank you very much to everybody for joining us today. We've had a really fantastic description of these phenomena that we're really trying to measure so that we can improve treatment, or we can help others improve the treatment of these really devastating problems in the future. We've heard about the qualitative work that's already been done in Raynaud's and digital ulcers, which has been really informative, and I think brings different things to our understanding and domain development from what's in the literature. The SLRs are not quite complete yet, and we look forward to hearing the final results, but fellows Nancy and Mike have been doing a great job being able to get that to this point. It's a relatively short space of time, so we're very grateful to you for all the work you've done so far. And we look forward to producing a Delphi in the next year or a few months, I guess, so that by this time next year we might be able to tell everybody what the group is starting to think will help us pull all of this together, and all of those who participate in the Delphi. So I hope you'll be part of that process.